Welcome. My name is Dr. Peter Tsmore, and my talk is titled Postoperative Outcomes of Ventral Hernia Repair in Veterans. The authors have nothing to disclose. Ventral hernia repair is one of the most common operations performed by any general surgeon. Although many different operative approaches exist, the two main ones are open and laparoscopic. No clearly defined selection criteria exist to identify patients' suitability for either type of operation. We believe it is important to compare outcomes of different surgical approaches and identify factors associated with adverse events. The objectives of our study include utilizing the VA Quality Improvement Database to evaluate the outcomes of ventral hernia repair in the veteran population, to compare outcomes of open versus laparoscopic approaches, and to evaluate the impact of BMI on postoperative outcomes. We queried the VASQUIP database from 2008 to 2015. Patients undergoing ventral or incisional hernia repair were identified using CPT codes. We then collected patient demographics, comorbidities, operative details, complications, and mortality from the database. The data was analyzed using appropriate statistical tools based on the type of variable and the type of analysis using the SPSS25 software. A total of nearly 20,000 patients were included in the study. Nearly 93% of them were males with a mean age of around 60 years. Mean BMI was 31, with 53% of the study population obese. Around 71% of patients had high ASA class, with about a third of them active smokers. Emergency operations comprised 3.3% of the cases. The rest of them were done electively. The open approach was used in 60% of cases and laparoscopic in 40%. Patients undergoing laparoscopic repair were younger, more likely to have lower ASA class, be obese, functionally independent, non-smokers, and to undergo an elective procedure when compared to the open group. For the entire cohort, the 30-day mortality was 0.5%, and complications occurred in 6.5% of patients. The laparoscopic group had longer operative time, lower requirement for intraoperative blood transfusions, shorter length of stay, lower morbidity and mortality, and less likelihood of postoperative admission. On multivariate logistic regression, the open approach was shown to be an independent predictor of mortality with an odds ratio of 2.1. Multivariate logistic regression showed that emergency repair, history of cardiac disease, and long operative time were independent predictors of mortality following the open approach. Conversely, none of these variables or any others examined independently affected mortality in patients undergoing laparoscopic repair. The open approach was noted to be an independent predictor of wound dehiscence, as well as deep and superficial surgical site infections. In contrast, the laparoscopic approach had a protective effect on the occurrence of wound complications. Trend analysis revealed that the morbidity resulting from open repair progressively decreased over the study period, while the complication rate following laparoscopic repair remained consistently low, with no significant change over time. We believe this improvement in open repair outcomes is reflective of our emphasis on preoperative optimization and planning. Looking at patient demographics, obese BMI classes were increasingly younger, non-smokers, and less likely to have COPD, with a higher fraction of patients presenting with diabetes and hypertension. Underweight patients, on the other hand, were more likely to have higher ASA class, be smokers, have poor functional status, and undergo emergency and open operations. There was a linear relationship between increasing BMI class and a progressive increase in operative time, overall morbidity rate, and specific complication rates for superficial and deep surgical site infections, DVTs, and cardiac arrest. The underweight subgroup had the highest length of stay and 30-day mortality. Obesity classes 2 and 3 were independent predictors for developing any complication overall, but particularly superficial surgical site infection and reoperation. This was only true, however, in the open group. Our data analysis resulted in these 4 main findings listed here. Our data has 3 main patient care implications. Number 1, during preoperative planning, the laparoscopic approach should be favored, particularly in high-risk and obese patients. Number 2, in high-risk patients, particularly those with cardiovascular disease, timely elective repair is advisable to avoid emergency situations. Number 3, preoperative optimization and multidisciplinary approach is recommended for the underweight and obese patients in order to improve outcomes. In conclusion, despite a high-risk veteran population, ventral hernia repair can be performed with outcomes comparable to that of civilian population. Morbid obesity has a negative impact on ventral hernia repair outcomes, most prominent in the Alpine approach. Laparoscopic approach offers superior outcomes, particularly when it's done on an emergency basis and in patients with cardiac disease. These are our references.